Hello and welcome to our 6-part series on back pain care. The purpose of these videos is to present a standard evidence-based approach for managing patients with back pain in primary care practices at UCLA. The videos have been designed to ensure that patients receive high-quality care while reducing unnecessary imaging. Another goal of these videos is to decrease unnecessary specialty referrals for the majority of our patients who have non-specific back pain that is likely to resolve with conservative management. In this video, we will be discussing how to manage patients with acute severe back pain. These patients may incorrectly believe that there is a treatment that will immediately resolve their pain. Therefore, the goal should always be providing a plan of care in which the patient will have confidence and reassurance that they will almost certainly improve with time. Indeed, almost 90% of patients with acute back pain seen within the first 3 days will recover within 2 to 3 weeks. Providing detailed instructions about a treatment plan, as well as handouts describing recommended positions and exercises, will go a long way in reassuring patients with acute back pain that their condition is being managed appropriately. We recommend using a 4-part conservative treatment plan based on the Saskatchewan spine pathway, an algorithm developed by the Saskatchewan Ministry of Health to help their primary care physicians manage patients with back pain. This treatment plan includes positions to relieve pain, movement exercises, medications, and possibly application of heat or cold. This pathway is not intended for patients with unusual and serious causes of back pain, such as osteomyelitis or cauda equina syndrome, and is limited to patients presenting acutely with musculoskeletal causes of back pain, including nonspecific back pain, as well as herniated disc or pain from spinal stenosis. A major advantage of the pathway is that it classifies patients into one of 4 patterns of back pain, with different treatment instructions for each pattern. Explaining this classification to patients may help them feel that their doctor is making a specific diagnosis that leads to a specific treatment plan, rather than just general advice to rest and take pain relievers. This may help the patient have more confidence in the primary care provider and be more willing to try conservative management. These are the 4 patterns of the Saskatchewan spine pathway, based on history and findings on physical examination. Pattern number 1, back dominant pain aggravated by flexion. These patients have more than 50% of their pain in the back or buttock, and their pain is worse with bending forward or being in a position of sustained flexion. The pain can be constant or intermittent, and the neurologic exam is non-contributory. Pattern number 2, back dominant pain aggravated by extension. These patients also have more than 50% of their pain in their back or buttock, but their pain is worse with extension, and the neurologic exam also is non-contributory. Pattern number 3, constant leg dominant pain, herniated disc. These patients have more than 50% of their pain below the gluteal fold, either above or below the knee. Their pain is constant. They have symptoms of radiculopathy, and they have positive findings on straight leg raise. They may also have other abnormalities on neurologic examination that are consistent with a radiculopathy. Pattern number 4, intermittent leg dominant pain, spinal stenosis. These patients also have more than 50% of their pain below the gluteal fold, either above or below the knee. Their pain is intermittent and changes with position and with activity. These patients are usually over 50 years of age. We will now describe the 4-part treatment plan for acute back pain. Position. The initial recommendations for positions to relieve pain vary by pattern. Patients who fall into either pattern number 1 or pattern number 2 may benefit from the Z-lie and knees to chest positions. To perform a Z-lie position, the patient lies with their back flat on the floor with their head supported by a pillow and puts their feet on a chair with knees bent at a 90-degree angle. To perform the knees to chest position, the patient lies with their back on the floor, slowly brings their knees up to their chest, and then wraps their arms around their knees and pulls forward toward their chest. Bringing up one leg at a time makes it easier. Patients with constant leg dominant pain who fall into pattern number 3 may benefit from the Z-lie as well as resting on their hands and knees. Patients with intermittent leg dominant pain who fall into pattern number 4 may benefit from the sitting flexion position. To perform sitting flexion, patients should sit forward in a chair with their feet flat on the floor, about hip width apart. They should then lean forward to rest their stomach on their lap and allow their head and arms to hang down toward their feet. Movement exercises. After a few days of performing pain relief positions, patients should be able to perform basic movement exercises. The most important exercise for patients with back dominant pain worsened by flexion who fall into pattern number 1 is the sloppy push-up. Patients should lie on their stomach with their hands in front of them and keep their lower body on the floor while using their arms to slowly raise their upper body. They should fully extend their elbows and slowly lower themselves to the floor. They should repeat this motion 10 times. Patients with back dominant pain worsened by extension who fall into pattern number 2 should perform trunk flexion. The patient kneels on their hands and knees, tucks their chin, arches their back. Then they slowly sit back on their heels, letting their shoulders drop to the floor. They keep their back relaxed and hold the position for 60 seconds. There are no recommended movement exercises for patients with constant leg dominant pain who fall into pattern number 3. Patients with intermittent leg dominant pain who fall into pattern number 4 may benefit from exercises that improve strengthening of their core muscles and muscles of hip flexion. In addition, they may benefit from the pelvis tilt position. To perform the pelvis tilt position, the patient should be on their back with their knees bent and feet flat on the floor, hip width apart, with their knees slightly closer together than their feet. They should then tighten their abdominal muscles and press the small of their back against the floor, which will cause their pelvis to tilt forward. Pictures of the positions and exercises recommended by the Saskatchewan Spine Pathway are available for primary care providers to include in the patient instruction field on the After Visit Summary in Care Connect. You will see 4 documents corresponding to the 4 patterns as options to provide to your patient. The third element of the conservative treatment plan is medication. Acetaminophen and NSAIDs are first-line evidence-based treatments. Benefits are modest, and studies suggest that they will decrease back pain by 10 to 20%. Explaining to the patients that these are only part of an initial 4-part comprehensive treatment plan may help to instill confidence. Muscle relaxants can also be very helpful for short-term use of 4 weeks or less in acute back pain if patients can tolerate the potential side effects of sedation or dizziness. Back pain guidelines do not recommend the use of opiates to treat acute back pain. If opiates are prescribed, the best option is to prescribe them only at night in order to help the patient sleep for a duration of 4 weeks or less. The fourth element is application of heat or ice. There's some evidence that application of heat or cold may help relieve back pain within several days. To apply heat, the patient may use hot towels, warm blankets, or a heating pad set on low or medium. There's less evidence to support use of ice, but patients who want to try this can apply ice to their lower back. To apply cold, the patient may use a wet towel placed in the freezer for 15 minutes or a bag of frozen vegetables. The majority of patients with acute back pain will improve significantly within 2 weeks if they follow a conservative management plan that includes positions to relieve pain, movement exercises, medication, and potentially application of heat or cold. We recommend seeing patients back in the office after trying this plan for 7 to 10 days. It is reasonable to continue conservative management for those patients who are improving, even if their pain is not completely resolved. For those patients with no improvement in their back pain, with 7 to 10 days of conservative management, video number 4 describes options for specialty referral, specifically physical therapy.